So join us. Thank you.
Thank you very much. So I'm going to be talking a little bit about one of my favorite topics, which is the cardiac arrest, and I'll show you the case, which was the first one we did many years ago. There were new resuscitation guidelines that came in 2010. If you look upon these guidelines, it's a big book. If you dig really far deep down into the book, you'll find this little part down here, where they actually say that mechanical CPR during PCI is a Class 2A indication. Now, even experienced interventionalists do not know about this because it's buried in the resuscitation guidelines, which is not often read by the interventionalist community. But it's there. The background for the resuscitation and cath lab is that it's due to cardiac arrest and cath lab. It's not uncommon, usually resolved with ventricular or defibrillation of VF. But sometimes you have extended, prolonged resuscitation, and those patients, they have high mortality rates. Effective manual chest compressions are difficult to do, both because it's difficult to reach in and during the procedure, an ongoing procedure, and do it effective compressions, and also it exposes the chest compressor person to significant X-ray exposure. Lucas is the device that we have used, which is an external device that compresses very effectively and can maintain circulation during cardiac arrest and allows for continued intervention. We know that the mechanical chest compressions can maintain a reasonable, not a fantastic, but a reasonable circulation. And this is mainly circulation for the brain. If we can circulate the brain, we can often fix the heart. And that's what it looks like in sitting on a cath lab table. And if you put a young doctor under it, it looks like this. And we've seen that it normalizes coronary blood flow and maintains circulation during ongoing cardiac arrest, can be applied quickly, and patients can also be transported with this. This is the first case in the world where Lucas was used during a coronary angiogram, which I did in 2004. And you can see here with the device turned on, you think that, did I make a mistake here? Is this actually good flow, or is the patient actually in cardiac arrest? But if you turn it off and then start it again, you can see the difference. It's very clear that circulation is provided. So what does it look like if you have, this is a patient, we're readjusting the Lucas, and then we're restarting it. So you can see PEA, and here we start Lucas, and you can see the blood pressure coming back. So seems to work quite okay on that part. Now, we wanted to go and also check out what could we do in this patient, and we went through the entire procedure, did PCI, and it works to do it. It's, you have to get used to it. It's not quite super easy, but it's, doable. And this was in 2004, so many years ago, but it's an illustration of what you can do. We ended up with this scenario anyhow, and the patient ended up dying. We went back to the lab and looked upon in pigs, and we looked upon coronary blood flow, and this is a flow map in the LAD of a pig, and the number you want to look at is this 9.1, which is the APV, and here we go induce VF, and you see the APV go down, then you start Lucas, you can see the APV coming back up. This is maintained for 20 minutes. And here we just stop and start Lucas again. There's some disturbances, but the APV is actually around 10, 12 here during this time also. So we go forward. So following initial stabilization with circulation, with mechanical chest compressions, there are some options here. If the cardiac arrest is quickly resolved with ROSC, for example, you treat do PCI of the left main, or what was the problem. We've had many patients that have then been able to take off the table and go back and do well. So some patients don't need any additive circulatory devices. In recent years, we have these devices that have come in use. So if the patients are in ROSC but is in shock afterwards, you can now go to Impella or ECMO or tandem hop, for example. And you can also do this while the patient is ongoing in cardiac arrest. And it's up to you if you want to continue with the mechanical chest compressions and finish the procedure, or if you want to stop, put the patient on some additive device, another type of LVAD, you can do that, then continue the procedure. But we have a whole host of options. And I think today what most commonly happens is that we will go to one of these devices as we need them. This is the ECMO device that I think is very commonly used now, where you can percutaneously go and put the patient on circulatory support with ECMO. You can have these primed and in your cath lab, and it can be primed for several weeks, standby, and it's a very quick procedure. Put them in when you need them. This is what a patient looks like, and this is when you have an impella that is used for venting the left ventricle at the same time. This is what a patient looks like with ongoing cardiac arrest and ECMO. You can also do other interesting things like putting them on bilateral or impella RP from the right side and impella CP on the left side, even though they're in cardiac arrest. 2015, new guidelines finally came out with the expert consensus statement for the use of these mechanical circulatory support devices. And I thought, wow, finally we know what we're going to do. Here we're going to have some serious advice. There was absolutely nothing in it. We are looking what is currently going on, and we are hoping that we will have more evidence in the future. It's basically what it says. So what is then the current evidence for using ECMO and all these devices in the cath lab? No evidence except registry data and anecdotal cases, although there's quite a bit of it now. Now there's starting to come some very interesting data out of especially the Henry Ford Clinic up in Detroit. So we'll see what happens. We can see here what can these assist devices deliver today, and what I have here encircled is pretty much what the delivery capacity is. And ECMO is the one that can deliver the most, but it's also a very interesting 5.0 liters per minute that can be delivered by the Impella 5.0. This is a very nice study which was presented or published by colleagues from Düsseldorf. It's a supra-institutional network for remotely picking up patients, going out to hospitals around Düsseldorf, patients who are in cardiogenic shock or in cardiac arrest, bringing that back to the mothership hospital and treating them. 115 patients, 77% of these patients were in cardiac arrest during ECMO placement, all of them at the local hospital. 44% survived to primary discharge. Of course, these are highly selected patients. These are then the survival curves, and we can see that the prolonged cardiac arrest in the older patient group was primarily where the large mortality was. This is another way to look at it, and you can see the outcomes down here. If we also look upon the patients who had shorter CPRs or no CPRs compared to the adolescents or younger patients, and then the older group where you had very, very high mortality rates. We know that these devices need to go in faster rather than later, so the earlier you implant, the better the patients will do. But these have to be very, very selected patients. There's a very nice ongoing Prague out-of-hospital cardiac arrest study. This is a hyper-intensive cardiac arrest study. Witnessed out-of-hospital cardiac arrest, they go either to mechanical chest compressions or standard of care, ACLS, CPR continued. When they arrive in the hospital, they're randomized, or they are then evaluated for ECMO at the ER immediately when they come there. And they have 170 patients, and they're almost nearing completion now. So this will be very interesting to see what they can achieve. And this is a little bit what we are looking at in the future. Lots of devices coming in here. The difficulty is going to be which patients are we going to select for this. The problem is they have very high mortality rates. They're very expensive to do, and we need to become better in understanding which patients will benefit. So there will be ethical problems. It's difficult when you put patients on these devices. You get circulation. Should you not do this to all patients that you think are reasonable or not? But there are horrific costs, and this is our big battle with our administrators currently. But you can look at things like this. This is what's happening in Paris. They go out in cardiac arrest teams. They have a patient who has been receiving CPR in the Louvre. They put the patient on ECMO and transport the patient back to the hospital for treatment. So in conclusions, I think that prolonged cardiac arrest in the cath lab, it's not uncommon. Most cases are solved with simple defibrillation. Our first priority is to restore a reasonable circulation for the brain. Then we have many options. We can stop and think and continue from there. Yeah, I think mechanical chest compressions can stabilize circulation quickly and allow you time to think and continue your PCI or start planning on how you're going to go and respond to LVAD devices or ECMO and so on. And randomized trials like the hyperintensive invasive Prague cardiac arrest trial are needed, and will be very nicely to see what they show. I don't think we're ever going to see a randomized trials for patients that go into cardiac arrest in a cath lab, though. I think we're going to make a decision there, either to go for devices, start circulation, or not. No randomized trial. Thank you.